Hi, everyone. Thanks so much for having me here to share some of my research looking at the impact of the patient-driven payment model on the delivery of therapy and patient outcomes in skilled nursing facilities. First thing I want to do is just quickly acknowledge funding sources supported this work. Generous funding from the Warren Alpert Foundation really helped to bring together a great team of researchers, co-authors listed here, myself from the University of Rochester, and colleagues from Harvard and Brown. So just to quickly kind of give everybody a little bit of background about what I think really brought about the motivation for implementing a new payment model in skilled nursing facilities, and in particular the patient-driven payment model, is the post-acute care setting was really identified as a key driver of both spending growth in the Medicare program and also geographic variation in spending in the Medicare program. So this chart really just lays this out here starting in 2001 and moving forward. Really rapid growth in post-acute care spending overall, and about half of this spending really being concentrated in skilled nursing facilities. So Medicare spending in SNFs became a key area of focus, was mentioned frequently in MedPAC reports, and really I think brought about a motivation to try an alternate method for paying for SNF stays. And I think another part of this story is that when we look specifically at skilled nursing facilities, we started to see pretty convincing evidence of decision-making within the SNFs that was probably not being clinically motivated, but was rather being financially motivated. So what do I mean by that? Here's one example from a paper of mine. So if you know anything about the Medicare SNF benefit for traditional Medicare beneficiaries, Medicare covers SNF stays in full so long as you had a 3-night hospital stay before, all the way up until day 21. Starting on day 21, patients become responsible for basically a 20% copay each day. So what do we find when we look at lengths of stay? We find there are lots of beneficiaries who are exposed to this cost sharing, who stay right up to day 20 and then are discharged on that day right before the cost sharing kicks in. Likewise, if you know the old system that predated the patient-driven payment model, the RUG system, you know that there are sort of magic numbers in terms of the amount of therapy delivered in the prior week leading up to an MDS assessment that helps determine how much the SNF gets paid. So if you get, for example, above 720 therapy minutes in the last 7 days, you're considered in this ultra high therapy category, which has the highest reimbursement rate. And so what we see is over time, skilled nursing facilities got a lot better at providing almost exactly that amount of therapy so as to maximize reimbursement. So anytime we see this sort of clustering around lengths of stay or therapy amounts that are being provided, and that clustering sort of matches up with some sort of a payment rule, that to us suggests evidence of sort of financially motivated decision-making rather than basing intensities of SNF care on resident clinical needs, which we sort of expect those to be sort of smoothly distributed. So with that in mind, enter the patient-driven payment model. It started in October 2019. Really the key here is that it really undid the tying of payment amounts to the actual amount of therapy delivered in the week leading up to each MDS assessment. Instead, payments are sort of determined prospectively based on how much a patient is expected to cost based on the assessment done at the time of admission. So when I say expected costs, this is taking into account things like how much nursing care and therapy the patient is expected to receive, some case mix adjustments, including the reason for the admission, presence of comorbidities, functional status, cognitive status, need for special treatments like perhaps use of a ventilator. So it really kind of changed the way that payment rates are calculated. Also relaxed some of the rules around the use of group and concurrent therapy and gave therapists more flexibility over this. I think important to note here that the patient-driven payment model was meant to be budget neutral, so it wasn't meant to reduce the amount nursing homes were getting paid for each patient, but rather just sort of change the calculus of how each resident a per diem payment rate was determined. But I think the key takeaway here really is it fundamentally changed the way that SNFs are paid and removed this incentive to deliver therapy up to certain payment thresholds and potentially over provide therapy. So with that being said, lots of interest in how this sort of fundamental change in nursing home payment impacted the delivery of therapy. Certainly lots of concerns leading into implementation of this policy that this would incentivize nursing homes to sort of skimp on therapy care and maybe under provide, and similar questions about how much therapy staffing they would keep on under this new payment regime. So with much interest, my colleagues and I undertook a series of studies to really try and dig into this and understand what the impacts of Pdpm were immediately after implementation. So the first place we looked was what was the impact of Pdpm on therapy staffing levels. So these results come from a paper we published in Health Affairs in 2001. The primary data source we're using here is the publicly available payroll-based journal staffing data that nursing homes are required to submit. This was kind of our first glimpse into quantitative data, giving us a sense of what the impact of Pdpm was. And perhaps not surprisingly, what we find is as soon as Pdpm kicked in on October 1st, 2019, we saw pretty sizable reductions and immediate reductions in therapy staffing levels. And you can see those staffing levels continued to decline a little bit during the first quarter of Pdpm. In adjusted models, we estimate that during the first quarter of Pdpm, OT and PT therapy levels were down about 5 to 6% relative to prior years, and therapy assistant amounts declined even more, about 10% relative to prior years. We also looked at whether these reductions differed by facility characteristics. In general, we didn't find a ton of variation with two sort of notable exceptions, I think. One is facilities that relied on contracting therapists, a contract staff model, rather than employing their own therapists, had larger reductions than those that used the employee model. And we also found larger reductions in facilities that had relatively more Medicare rehab patients that were sort of directly impacted by this payment change. So we know staffing levels were down, therapy staffing levels were down following implementation of Pdpm. The next sort of follow-up question is, what was the impact of Pdpm on the actual amounts of therapy that are being delivered? And going hand in hand with that, the resultant patient outcomes from any potential changes in the amount of therapy being delivered. So these are results from a follow-up study done using the minimum data set, the assessment data that nursing homes are required to collect on residents. We published this in JAMA Health Forum a few months ago at this point. So here was our first opportunity to sort of look at actual therapy amounts being delivered to residents, and then to look at a couple of crude measures that we can construct from the MDS data related to patient outcomes. So I think, a top line result here is you can really see when we shifted from the RUG system with those sort of magic threshold numbers to the Pdpm model, is we went from that very clustered pattern of therapy delivery where patients were really clustered right in the 720 range to get to the ultra high therapy category, and right in this 550 range, which is the threshold to be in the high category, to now in this lighter blue, we have the Pdpm model, where now we essentially have a smooth distribution of therapy minutes being delivered by the time of the 5-day assessment. So this to me suggests we drastically shifted from sort of financially motivated decision-making around how much therapy to deliver to something that looks much more consistent with what we would expect if therapy amounts were being prescribed strictly based on patient need. And this is kind of showing a similar result, that in addition to smoothing that distribution out, on average, we find that therapy minutes are down by about 13% overall. So one thing I wanted to mention here, for the main results in our paper, we're primarily looking at patients who underwent hip fracture. In some sensitivity analysis, we look at all patients admitted after Pdpm, but hip fracture patients we thought were a nice sort of test case because their therapy needs should remain pretty consistent pre and post Pdpm. So as I mentioned, about a 13% reduction in total therapy minutes overall is what we estimate in the post Pdpm period. What we find is actually that's driven by about a 16% reduction in individual therapy minutes, which is what's being shown in this graph here. You can see that change happened pretty much overnight. And sorry, jumped ahead there. And it's offset somewhat by a small increase in the non-individual therapy minutes. As I mentioned, Pdpm relaxed some of the rules around that, and we were finding therapists were taking advantage of that up until COVID hit. And at that point, group therapy was pretty much zeroed out. So keep that in mind as you're looking at some of these tails on here. We have kind of a COVID story baked into these results as well. I'll say more about that later. So in this bottom row here, we kind of jump ahead and also look at some patient outcomes. So the crude measures that we're able to look at in terms of patient outcomes are any hospitalization, were they readmitted to the hospital? Did they have to stay in the nursing home longer as measured by a length of stay because they got less therapy? In these two graphs, we see no evidence of a discrete change in either of those outcomes, suggesting that the reduction in therapy did not worsen outcomes for these patients as measured by hospitalizations and length of stay. When we look at this by change in ADL score, both at the time of admission, this darker blue line, and then at the discharge assessment, the pink line, again, we're really not seeing any discrete changes in those, particularly at the discharge assessment, suggesting that outcomes also were not observably worse on this measure of change in ADL score at the time of discharge. These are just results showing how things look when we look at all patients, not just restricting to hip fracture patients. And I think just the key message here is very consistent results regardless of whether we're looking at the full sample or that kind of test case of hip fractures. So in terms of kind of summarizing those key results from those two papers, again, Pdpm obviously removed the incentive to provide maximum therapy amounts to hit those payment thresholds. And as a result of that, we found what I would describe as a modest reduction in therapy staff hours, about 8% overall, noting the larger effects in the therapy assistant category. We find that this translates to about a 13% reduction in therapy minutes delivered to Medicare patients. And we find no evidence of worsened health outcomes for Medicare rehab patients on these sort of three preliminary crude measures that we're able to look at with the data we have available currently. So again, those are rehospitalizations, SNF length of stay, and ADL score at discharge. So one question we might want to ask here is, based on this early sort of preliminary data, was this a policy success? Certainly it normalized that distribution of therapy minutes provided. I think I would characterize the staffing reductions as being a bit more modest than perhaps originally feared. And so far, the existing evidence suggests that the reduction in therapy minutes was really more of a right sizing of therapy as opposed to cutting back on therapy that was critical to patient outcomes like rehospitalizations and length of stay. One thing we need to point out here, though, is we really have an incomplete picture of what the effects of PDPM were. We had this great sort of natural experiment that entirely got blown up by the COVID pandemic that started end of February, beginning of March of 2020. And that really, limits our abilities to understand what the long-term implications of PDPM was. And then I would be remiss if I didn't mention, at this point, PDPM has not delivered any Medicare savings. In fact, recent estimates from MedPAC suggest that it's actually increased per diem payments by about 7% during the first quarter. So currently those payments, Medicare is paying more under this regime than it was pre-PDPM. So that sort of leads me into my last point here, just about where we're kind of heading next with evaluating PDPM and understanding its impacts. So I think one thing is we need to sort of understand what the therapy delivery looks like in a post-COVID. And I realize I sound like a true optimist using the phrase post-COVID, but as we return to more of a normal, what does this look like, PDPM in a post-COVID era? And also post-CMS payment adjustments. So CMS has already said they're going to start to claw back some of that additional payment. I mentioned the 7% earlier. There's a 4.6% reduction scheduled. So we need to understand what therapy delivery looks like as the budgets start to tighten up a little bit. Also very interested in sort of spillover effects from PDPM. So I've already mentioned about a 13% reduction in individual therapy minutes delivered, or total therapy minutes delivered. That's a bit more than what we estimate in terms of a staffing effect. So there's some question of, are staff more available to work with potentially the long stay patients under Part B? What is the impact of Medicare Advantage patients, which Medicare Advantage is becoming an increasingly common form of coverage in the Medicare program. So we need to understand kind of the spillover effects to these other patient populations. And then the last point I want to highlight here is, I've said a couple of times we use crude outcome measures. We certainly understand the criticism that therapy and rehab is not necessarily designed to prevent rehospitalizations, but rather improve function. So I think this really stresses the need to get better at measuring rehab-related outcomes so that we can really understand the true effect of PDPM on patient outcomes. So I'll stop there and say thank you very much, and happy to take any questions when the time comes.